Audio recording for this meeting has begun.
Okay, great. That is a good amount of results, and it seems like a good amount of you are pretty confident in your MSM services. That's great to hear. David, I'm going to hand it back to you.
Okay, great. Thank you for that technology bit of employing the poll thing. I love this stuff. It's great to be using this. So thank you all for completing that little quick poll. So continue on in terms of the objectives and goals for today's session. First of all, our objective for this series is to do some pretty obvious things. We want to be sharing strategies. We want to be identifying and improving the strategies that work for all of you on the ground and increase our efforts to promote peer-to-peer assistance and promote collaboration. So for today, in the context of the MSM tool, we're going to be walking through and introducing you to the tool. It's a slightly different version of the tool that you may have seen before. We want to hear from all of you to help identify areas that may need to be improved. And on the larger questions of NCSD's work in general on MSM issues, we're very interested in hearing your feedback, guidance, and direction about how you think we should proceed as a national organization to be enhancing our work in this arena. Most recently, I think most of you know that I've been with NCSD for a year and a half. Taking on any new job, it takes you a good 6 to 8 months or more to really learn the organization to get firmly established. And I feel like it's been a great year and a half, and I now know that much more about our immediate sector and the work of NCSD. And I think we've made a lot of changes in the past year and a half, and so I'm very excited that we are taking on the charge around how to work with all of you to enhance MSM services. So we will be leading the charge to do webinars. We'll take this immediate tool and use it as well at STD Engage, and we want to be encouraging its use. And Neel, am I on target for our slides? No, I've gone completely out of order. How about that? Hold on 1 second where I am. I have the wrong order of slides here. Let me pause and go back and cover what you see on your screen here. I think some of you have seen our history in doing some work in this arena. We have, if you're not familiar with these things yet, you can find all of these things on our website. But we do have an MSM services report card. We have the MSM Sexual Health Standards of Care, which were in development for several years, and we were thrilled to release a few months ago to very good reviews from the field. We have hosted focus groups where we pose some really tough questions about what we are or are not doing to reach young people around current messaging around PrEP and condom use, and I think there's some very important findings from those focus groups to be reviewing. We have in the past also developed a stigma toolkit, and of course we have worked for a number of years to have a joint work group with NASTAD around some of these issues, and then most recently we have formed an MSM Health Equity Working Group, which is a body that works with the staff but is also empowered to be advising our board of directors. Internally at the staff level, we've been doing several things as well to be engaged in professional development for our staff. And so we've been doing a series of brown bag lunches on the part of our staff where we've really delved into a set of issues and discussions that are designed to help elevate our dialogue around these issues as a staff so that we're doing a better job of serving the field. There is a history to this particular tool that we are talking about today. And so the slide that I'm referring to right now is the history of the MSM Services Report Card. Where in the world, of course, is this? So What we are discussing today is a next iteration of this tool, and it differs a little bit from the work that we initially did through the Gay Men's Health Equity Work Group, which was a joint effort with NASDAD. Initially, this is a tool that, the tool that we're discussing today resembles more of the original version of that tool, which did end up getting changed a little bit when it was sent out a few months ago. I think we're retrenching a little bit today to take that back and to return to the original intent and use the tool as a self-assessment tool for you all to use in the field. I think we probably dropped the ball a little bit on this when we first issued this jointly with NASDAD a few months ago. So now is our opportunity to kind of revisit this, take it to the next level, and really learn and assess how this can be of assistance to the field so that we're employing this as we go forward. So the other slides, did I already cover the other slides? I'm completely out of order. Oh, I was referencing this a little bit a moment ago, but as we go forward, I had mentioned that our goal is going to be to continue a webinar series on this. We'll employ this tool and have a session on this at STD Engage in the fall, and we'll be doing more efforts to encourage the use of this by members. So in wrapping up my introduction of this, I think that covers everything that I wanted to cover. I look forward to hearing the overview of the tool and to hear, Tom, your presentation, and then as well very much hearing the feedback from everybody in terms of how we move forward to implement this. So thank you, Neel.
Thank you, David. I really appreciate that. Thank you for setting the ground and the context for this discussion to follow. I think it'll be really helpful. And Tom, if you want to take it away, and I think you might be able to switch your own slides. If you don't want to do that, I can do it for you. But the platform is yours, Tom.
Okay, thank you, Neel. Hey, Neel, I want to confirm, did everyone who signed up for the call get sent the Excel spreadsheet that you had prepared?
Yes, I had sent that out, yes.
I referenced it. Okay, all right. Well, yeah, I'm happy to jump in here. Just to introduce myself, I'm Tom Bertrand. My current role, I'm at the Rhode Island Department of Health, and I'm the chief of the Center for HIV, STDs, Tuberculosis, and Viral Hepatitis. I've been an active member of NASDAD and NCSG for a few years. About 2 years ago, I introduced the topic of addressing gay men's health equity as part of a NASDAD NCSD work group, and had my own idea about how we might be able to move forward with the goal of states being able to share best practices in one way or another regarding health equity. Having said that, I know when I first heard the term health equity, I just made an assumption that it was the same thing as equality, and I learned quite differently. They're actually opposites of each other. So I wanted to talk just briefly first about the difference between health equity and health equality before we get even into some of the meat of the presentation. I also want to start off by acknowledging and thanking three of my colleagues, Bryce Furness, Dan Daltrey, and Dan Wolfeiler, who've been part of the ongoing conversation I've been having with them to help roll out some type of support systems and a concrete plan to move forward around gay men's health equity that would be useful and practical for state health departments. So what you see in front of you on the slide is my really big aha moment about what does health equality and health equity represent. On the left-hand side, you see three individuals who could technically represent three groups of populations, all standing on one box with the goal of looking over a fence to see a baseball game. And as you can see, that the shorter person can't see anything, so they have a disadvantage. The tallest person is way above. And this is equality. You gave everyone one box with the goal of achieving something, which is seeing a baseball game, and acknowledging that there may be barriers that need to be addressed. But it doesn't accomplish it for the shortest person there. Equity is when you do something very differently, and it's actually the opposite of equality. And that means that you're actually giving one group, or trying to level the playing field. And that means sometimes giving one group more boxes or more services or enhanced services over another group. I won't get into it on this call, but one of the unique things about this slide in my mind, too, is that that extra box that they gave to the short person, they actually took away from the tall person because that person didn't need it. But that's a very controversial issue. And what it comes down to for me, too, when I talk about gay men's health equity and partner services, sometimes I say some controversial things, but I'll talk to programs and I'll say, so how are you helping gay men when it comes to partner services, when it comes to syphilis or HIV? And they assure me quite happily, Tom, I do the exact same thing for all people regardless of who they are. We do not discriminate, and everyone gets the same exact services. And that's when I push back and I say, well, you're doing health equality. You're giving everyone the same services exactly the same way, but you're not achieving health equity, which means giving a bump up for gay men perhaps for any number of reasons. And they said, well, what are you talking about? And I said, well, with gay men, do they get an option for either talking to a gay person who might be part of the LGBT community or a straight person? Do you have a website where you describe partner services so that gay men don't feel alienated from their state government about why are you prying into my business? And so I just think it's really important for us sometimes to step back, that when we think if we're doing everything the same for all populations, we're achieving health equality but not health equity. By what we need to do is acknowledge that some groups, including gay men, and this is the argument, have some disadvantages or have experienced some barriers in life. That means for us to do our jobs better that we have to step up our efforts in one way or another. I'd also acknowledge, too, in terms of even just health equality, in some cases, we're not even inviting gay men to the baseball game to even watch it, that they're completely left out or missing. And so one of the things, too, some people say, well, if we, rise, that term, rising tides lift all boats, that is not health equity either, because when you rise all boats, they all go up together at the same rate, and some boats have more challenges than others, and may sink. And so the point of our conversation on health equity for gay men is how can we step up our efforts above and beyond what we might do for others? And in some instances, we're just trying to achieve health equality. So I hope that makes sense for people. So let me give a little bit more background about this and how 3 or 4 years ago, I was actually in the community. I ran an AIDS service organization here in Rhode Island, and I had a hat on as an advocate to ask critical questions of the health department. And I'll just be frank here. I'd go to many, many presentations from the health department, and they'd give these big data presentations, and they would provide incidents for HIV by sex, by age, by race, and city and town, but not by sexual orientation. And I always thought that was quite strange, given that gay men in general as a population were hardest hit, and there was no visual representation or even analysis that how is the incidence different and how are they hardest hit. So I always thought that was always very concerning to me. They were left out of that. Second, why do 30% of HIV case reports lack risk factor information? I was very concerned about this, and a lot of people surmised that many of the case reports that lacked case risk factor information were for gay men. So I said, how much are gay men actually being underreported? Do we really understand the true burden of HIV in our state? I also wanted to start asking questions. I was an old STD person, and I was kind of new in the HIV field. And I said, well, what are the changes in sexual behaviors amongst gay men in the past 30 years? And quite frankly, if you ask that question in Rhode Island, people would say, I have absolutely no idea. We never bothered to collect on a statewide level BRFSS data for sexual orientation, which I found somewhat alarming. We were 30 years into the epidemic, knowing that gay men were hardest hit, and we absolutely had no data whatsoever to tell us, is condom use going up? Are they seeing doctors? Are they using condoms? How many partners? What are the trends? So I found that somewhat alarming. I also did my own analysis around HIV prevention funding and if it was proportionate for the burden of disease amongst gay men, and gay men came out very, very low relative to other groups. And then finally, why is HIV epidemic among MSM buried or missing in press releases or other data documents? I would read things like the HIV epi profile, and often I'd get to page 20 out of 60 pages, and there'd be a chapter on MSM, and the first time MSM are referenced. And I always thought that was quite strange because I knew that MSM were at the center of the epidemic, and they were referenced just as yet one other chapter when you were comparing by sex, by age, by race, by ethnicity. This was the primary transmission mode. And it was interesting for me, too, because there was a World AIDS Day, and there was a feature article in our Providence Journal, and the highlight there was that some women were getting HIV from bisexual partners. I was like, well, that's not the major headline here. It's an important topic, but those number of cases were minimal relative to others. And I actually called the Providence Journal reporter, and I said, why was this your headline? And she said, well, that's what was in the EPI report. That was one of the first things that I read. And so this stuff is meaningful. And I started wondering to myself, how can we better count gay men in the work that we do? And this kind of transformed into the work to what we're talking about today. So I just want to give a little background. I think this may be obvious to many of you, but I wanted to share with you my little history on why do we consider MSM a group that might benefit from being a focus of health equity work. And in terms of our history as a country, there are many angles to this. First, in terms of discrimination, gay men have been the target of overt discrimination when it comes to housing, military, employment, medical facilities, blood and tissue donation, and same-sex marriage and hate crimes. In terms of societal acceptance, the most recent data I could find from Pew Research is that 40% of Americans report that homosexuality is not acceptable. In terms of illegal sexual behaviors, as of 2003, same-sex activity was illegal in 14 states. The proxy for this was basically sodomy laws, as well as Puerto Rico and the military. So, and many gay men were born before 2003, including myself, and so we were alive and sexually active while many of these laws were in place. Health disparities, in addition to STDs and HIV that we know, tobacco abuse, alcohol abuse, anal cancer, violence, eating disorders, depression, anxiety, suicide, and substance abuse are all higher amongst the LGBT community. And then I do want to drive home the point, too, that it's all not behind us just because gay marriage was passed by our Supreme Court recently. There still remains a national debate and controversies on many LGBTQ rights and services in terms of same-sex marriage, banning conversion therapy on minors who identify as LGBTQ, protecting LGBTQ people under sex discrimination policies, and also religious freedom laws that are designed to deny services by individuals who are aligned with certain religions. So this is all current, and I think it alienates gay men in many ways, and especially in terms of their relationship with health departments, which I think is really important. When we call up and we're doing partner services and say, hi, we're from the health department. First of all, we know you're a gay man. We know you've had sex, and we want to talk to you about partners. How does that feel to individuals who might be identifying as an MSM? So that's the background of what I think we need to push this. And then on top of those challenges, I just wanted to share some of the Rhode Island Department of Health data very simply for the past few years that shows the great disparities with MSM compared to other groups. The first slide here is for newly identified cases of HIV by mode of exposure. The y-axis is the number of cases. The x-axis is from 2005 to 2014, and it's a segmented bar graph, and the blue bars are gay and bisexual men. So you can see for HIV, we pretty much have not made a whole lot of inroads in terms of decreasing new diagnoses. For infectious syphilis, again, the graph is on similar to HIV with years on the bottom and number of cases on the y-axis. And as you can see, I think this is across the country, we're seeing infectious syphilis explode amongst gay and bisexual men. If I brought, we're over 100 cases now a year in Rhode Island, and it continues to grow. And then finally, for gonorrhea, the picture isn't quite as bad, but I think we've seen all increasing rates of gonorrhea. And again, the blue part of the segmented graph is for gay men, and they're pretty much driving many of the increases that we're seeing in Rhode Island. So given this intersection of both the history of the treatment of the LGBTQ community in the United States, as well as these rising rates, I do think there's a really big opportunity for state health departments to step up more. Having said that, I think what's really critical is that none of us have had a roadmap. You know, no one's ever brought up the actual, what is an ideal set of services the health department provides and activities to achieve health equity for gay men, and then how do we stand? And then on top of that, how can we actually work with each other, because some states are actually doing some extraordinary work that we can learn from. So some of the gaps and opportunities, and this was, you know, in the works for the past year or two that we had identified for how can we move the needle forward, advocating for the inclusion of sexual orientation on national and local behavioral health surveys, including the WIRE-BS, as well as the BRFSS. One interesting point about the WIRE, the Youth Behavioral Risk Factor Survey, when I've worked with the CDC on this, they actually give an incentive to states if they include sexual orientation on their WIRE-BS, and still participation by states to include that is limited. And so I think that's ironic in many ways. Second, providing technical assistance to STD and HIV programs for calculating HIV and syphilis incidence for MSM. This is an important topic because it actually demonstrates the impact on the community of gay men. In the past, I had received pushback on this, saying, well, Tom, we don't know the population size of MSM in our jurisdiction, so we can't calculate this. But some really great researchers and scientists at Emory University have taken this on, and they've established some really important data by states that can help us do this. Advocating for HIV screening among MSM to be a HEDIS measure, similar to chlamydia testing for sexually active young women. Thought it might be an opportunity to motivate health plans to prioritize gay men as a group that should be screened and have this be a national measure, and perhaps be part of a pay-for-performance program. Measuring the MSM representativeness on HIV and STD program planning groups I thought was important. At least in Rhode Island, I felt MSM were severely underrepresented. A few more here. Measuring whether community-based funding for MSM is proportionate with HIV disease burden. Finally, which I'd mentioned before, from a surveillance perspective, working harder to reduce the number of HIV case reports with no identifiable risk to ensure that all MSM are counted in surveillance efforts, which means actively reaching out to reporting providers and trying to determine the mode of exposure for their cases. And then finally, helping MSM navigate the healthcare systems and identifying providers that are sensitive to their healthcare needs. I did a survey in Rhode Island recently amongst 200 gay men. 98% of them had a regular doctor, but only 66% of them were actually out to their doctors. So they're clearly not receiving the care that would be prescribed according to guidelines. And then also, and why we're here today, is considering a gold standard for what I called at the time counting gay men, counting MSM as a report card, a self-assessment, or through national awards to identify those states or jurisdictions that are actually doing a good job with this. So I want to introduce the tool which we had proposed. You all received a copy of it from Neel today. It's actually an Excel spreadsheet that I had created, and you all are kind of acting as a focus group today, to be quite frank with you, to help make sure that what we're working on is user-friendly and practical. I had never envisioned, to be quite frank with you, that it would be sent out in a version of an Excel spreadsheet. I was doing that as a working document with the goal of having it being fancier, but it does serve a purpose for today, and I hope some of you had a chance to take a look at it. But the entire idea of this tool are a couple of things. The idea was that it would be a target, the target audience would be HIV and STD directors and their staff in health departments. In catchment areas that could be used at a city, state, or county level. Idea would be to have 20 multiple choice questions that people could choose from. You could complete it in 10 to 15 minutes, making it fairly simple and straightforward. Have a grading system just to set a bar for states about where they stand in terms of their efforts. Listing of peer technical experts was actually one of the most important components of it, that if there was one element or a few elements of the report card that your jurisdiction was scoring poorly on, you could easily reach out. Voluntary and confidential, you'd receive it and you would administer it as you see as you would like in your jurisdiction. You don't have to report anything back to anybody. And then finally, it's continuing, evolving, and improving. I think this is a very novel approach to addressing health equity, and we're learning and trying to make it worthwhile for all states and make it available in a way that is practical and convenient. So again here, the primary goal here, to be quite frank, is not just to get a grade or get an A+, but actually identify your weaknesses and then also have a really easy way of reaching out to somebody in another state or from like an Emory University to actually get assistance as you see fit. So I think we're going to stop here and do a poll. Neel, I'll let you run with this.
Yeah, thanks, Tom. So a quick interjection here. I am going to put this poll in your view. Okay, so here's the second poll, and it is, what are the gaps in the current services you provide MSM? So if you could take a minute to fill that out. Cool, so it looks like we're getting a good range of responses here. And it looks like the most are, oh, nope, changing. Cool, so it seems like there's a need centered around data collection and providing relevant services. And this is really helpful to us because we're going to use all of these responses and talking about how to improve this tool later on. So this is great. Okay, Tom, back to you.
So what I thought I would do, there are 3 areas, to be frank, of gay men's health equity that I think we've advanced fairly well in Rhode Island. And I wanted to share these examples with you guys just to say, oh, this is what Tom was getting at. It's just how can we feature good work at different program levels and easily access it and say and identify colleagues who can provide technical expertise. The first one is creating a health department webpage for gay men's health. I believe, I could be wrong here, we're the only state in the country that on our health department website, we actually have a page dedicated for gay men's sexual health. And it was very easy for me to put together. This is it. It has lots of links out about how to use a condom, how to ask, what questions you should ask your doctor if you're a gay man, how to find condoms, some links to the CDC. And so I just want to share this with the group as something that was very low cost and took me about half a day to put together. And I really encourage, given what's going on with our STD rates, that all states should have such a page. The CDC has pages dedicated to gay men's health, and I think every state would benefit from it so that people can get local information. The second example I wanted to share with the group, and again, these are just examples of things that might be an aha moment of, wow, I could call Tom and find out about this. So when I was working at AIDS Project Rhode Island 3 years ago, and I had a focus group of gay men together, and I had in my mind, how can I best get you screened? How can I best get you to use condoms and reduce partners? And they all pushed back at me very hard and said, Tom, we don't want your help with that. We know all about it. Just help us find gay-friendly doctors in Rhode Island. And I listened to them. And so what I worked on, and this only cost me $5,000, was a website called men2menri.org called Rhode Island Living. And it's a website that's local to Rhode Island that gay men can visit that have had over 100,000 visits since it started. But you can see in the top right there, Play Safe, there's information on sex, drugs, and you, finding a doctor, getting health facts, and getting connected to the Rhode Island scene. And I'll just go a little bit deeper into this. Here's the page on how to find a doctor in Rhode Island. It's really quite simple. And on the right-hand side, you can click on Find a Doctor, or you can recommend a doctor. And people said, well, Tom, how did you come up with this list? And we just decided to make it a consumer-driven web page, pretty much like a Yelp, where gay men can actually enter their doctors, their dentists, their psychiatrists, or counselors. You can't see it very well. You can go on. It's a live website. You can always go onto it. They can click on those different tabs on the bottom there and see the names of doctors or other healthcare providers that other gay men have recommended. So this was a simple, easy opportunity for me to at least promote some word-to-word, mouth-to-mouth conversations about this. One other piece that we also added to this is a lot of gay men are afraid to ask questions around their health. We have there's a web page for Ask Dr. Phil Your Health Questions, so guys could ask questions that they had, regardless of how personal or sensitive they are. And then finally, from a health equity perspective, a lot of gay men feel alienated or in the closet, struggle with coming out, and so we created a page called Get Connected that does assist gay men coming out of the closet, finding boyfriends. Yeah, I'm looking at the right-hand side there. Make a difference, places where they can volunteer, and then information for people who are positive that might be support groups. So again, just wanted to share this with the group and let you all know some of these are really, I would say, low-hanging fruit for things you can do in your states. And then finally, I'd mentioned before how we're seeing rising case numbers for syphilis and gonorrhea in Rhode Island, and that ongoing HIV has been a significant problem. So one of the things we've done is to this is a recent surveillance report that we put out that includes HIV, STD, and viral hepatitis information. We actually have a section in here on gay, bisexual, and other men who have sex with other men. And one of the pieces here, which I think is really important, is that we've actually calculated the incidence of HIV and syphilis for gay men in Rhode Island and compared it to heterosexuals. And this slide you see in front of you are the case rates per 100,000. And as you can see, this is a very different representation than the segmented bar graphs that I saw presented before. You look at these, and for heterosexual males, they hardly even register on this figure. And then again, for infectious syphilis, again, I can't even do a line graph because you wouldn't even see the numbers. And this just demonstrates, I think, another issue around health equity, that for us to actually demonstrate and show the true impact of these diseases on the community of MSM, calculating incidence is so critical. So I just wanted to share these with you all also. And then finally, what you probably received today from Neel is the sample report card as it stands right now. It could be evolving. I think eventually we'll have it on the NTSD website as a resource. But the idea here was to be able to have a question or the element of what represents MSM health equity, be able to answer a question on kind of with various answers from between 1 and 4. And then on the right-hand side, which I think is the most critical piece, would be that if you wanted to learn more about this topic, you could easily click on a person's name and write them an email, or actually click on a web page that might give you more information. And this is what you do at your own discretion. So I just wanted to share with you, when I first started this project, I just wanted to have 4 or 5 questions to help people guide their health equity efforts. We quickly expanded that to 20 based on input from both HIV and STD colleagues. But this was the concept here of, and I just want to share, I think there are 3 or 4 sample questions if you haven't been able to look at them. Does your jurisdiction use online or dating hookup apps or websites as part of your HIV STD Partner Services program? Possible answers: no, we're exploring it. We have a system in place, or our jurisdiction has a system in place, and we're evaluating its effectiveness. Here's another sample question. What's the current status of collecting sexual orientation on WireBS and BRFSS? Not included in 1 or 2 of the surveys, included in both. It's included, weighted, analyzed, and published in formal reports for both surveys. And then finally, this last question, does your jurisdiction collect and analyze partner services metrics for MSM for HIV and syphilis? and use the information for the purpose of program improvement. No or yes, we do calculate it. One step up, yes, we calculate it, and we use the findings to improve partner services outcomes. Another topic, does your jurisdiction support non-genital STD testing for MSM? Bryce Furness has been a very strong champion for this. We don't, or we provide technical assistance, we provide funding, or jurisdiction conducts non-genital STD testing for MSM. So this was just to give you a taste of how we came up with the questions to make it applicable to programs and understand you could be at different points along a spectrum of achieving health equity and seeing where you can go with it and being able to step up your efforts. So Neel, we have another poll coming right up.
Yeah, this is a third poll, and this asks, what sections of the tool would you prioritize as a webinar? So this is for us to gauge interest in this as a webinar topic and what sections you want us to explore a little bit more. So everyone, please take a minute to fill that poll out. Great, that is really helpful. And it looks like that it's, again, data analysis and social context, so that is good to know. All right, Tom, back to you.
Okay. So we're at the stages, as David Harvey mentioned it before, we're resurrecting this tool. There had been some versions in the past, and now there's a strong commitment to dusting it off, improving it, and ensuring that it's something that would be of practical use to project areas. So what we're looking for, and I think Neel will be reaching out to members of this call and others, we'll be looking for volunteers to be end users to test revised versions of the assessment before we do a complete rollout of it. We'll be looking for volunteers to be listed as peer experts on the assessment. Again, here, people have asked me, well, what criteria do I have to meet to be a peer expert? And to be quite frank, it's just your willingness to volunteer makes you an expert enough. There won't be any formal process. Clearly, we'll be looking for our members to be experts, as well as recommended partners in the field. We'll also be looking for support to complete the assessment with, once it's ready, with internal stakeholders, seek technical assistance, and develop an MSM improvement plan. The goal here, too, would be not just for STD and HIV directors to do this survey in an isolation of their own office, but potentially to share it with staff, use it during staff meetings, and have it be an opportunity just to prompt discussions. And then also provide informal feedback on the assessment on an ongoing basis to see if it needs to be revised, new elements, or new answers. So that's the stage we're at right now. And let's see, there's another poll here.
Okay, so this is the last poll, and thank you so much, Tom, for that wonderful overview of the report card. That was excellent. But for right now, I'm going to direct everyone again to the corner of the screen, and I'm putting it there. It's how should MCSC highlight the report card at our annual meeting? And we're going to make it bigger. Hold on 1 second. Cool. So it seems like there's a lot of interest in having it as a concurrent session. Great. Well, thank you for the participation in those polls. Those are going to, like I said, those are going to be extremely helpful going forward. So we just want to talk a little bit more, and this is just, I don't even think I introduced myself. I'm Neel Rana, the Health Equity Manager at NCSD. And we want to talk a little bit more about how NCSD envisions its own future of our MSM-related work. So, sorry. Oh, I skipped one ahead. Okay, so where are we going from here? So, NCSD desires to construct a clear roadmap related to our MSM outreach. So where can we start building? The questions we really want to know are, where can we start building our programs, and where should we be headed? Some things we have in mind for ourselves is a renewed focus on MSM communities, with particular attention paid towards MSM communities of color, focusing on the prevention of STDs and the promotion of healthy sexual habits, and because we are a membership-based organization, we want to help our members in their MSM outreach. And all of these questions, we want to hear from everyone on this call on what you envision us doing in these specific subjects. So all that to say, essentially the question we're asking is, what else should NCSD be doing in addition to this, to improving and disseminating and promoting this report card and self-assessment tool? What should we be doing to improve our outreach towards MSM communities? And the arrow isn't really pointing to the chat box right now, but the chat box is in the lower right-hand corner of the screen. And if you have any suggestions or any thoughts that you want to share, please, I encourage you to type that into the chat box. And the last portion of the webinar, I wanted to open it up to some questions. We still have David here. Tom is also still on the line, and I'm here as well. So if anyone has any questions, you can either unmute, or actually, we can't mute the phones. If you have any questions, please type it into the chat box or the Q&A box. Either one works. And you can kind of direct it towards whoever you'd like to, and we'll try to answer them to the best of our ability. But we'd love to hear from everyone. So I'm going to give everyone a few minutes to open up the floor for discussion a little bit. And Tom, if you have anything you'd like to add, feel free.
Okay, thank you.
So Ronnie Boone says, inform the MSM community that public health is not the enemy. I'm gonna open up to anyone to talk about this. So David will start us off.
Well, Tom, I'll be interested in your thoughts on this, and other people may want to weigh in as well. But Ronnie, I think that's an important observation. We do have some barriers, I think, to overcome. I think there is, since I've joined the STD sector for the last year and a half, I've heard feedback coming our way, and there are historic barriers that we probably need to work to overcome. Some within the HIV-specific community view the STD sector as not up to date, as overly focused on contact tracing and partner services, that somehow we are the sex police, and that we are not embracing and encouraging of the gay community. We know that MSM and the gay community are disproportionately impacted by STDs and HIV, and yet we have some of these barriers to overcome. So I think it's very good you offered this observation, and I think one of the very goals for doing this webinar and dusting off this tool and enhancing its use is so we can start to do some things in some dramatically new ways that will communicate to the community that we care, that we hear the concerns, that we are working to address community needs, and that we're going to go about this work in a new and different way. So I think your statement is very relevant to some of the challenges we have. Tom, do you want to add anything to that?
Oh, yeah. Ronnie Boone, I want to thank you for raising this question, because what it hits home for me is I've been at many meetings, and actually at the last NCSD meeting, where many of my colleagues and the presenters like, we need to educate, we need to inform, we need do all types of things to tell people in the MSM community what they need to do and do better. I think the opposite. I think we need to listen. And I think we need to listen to the fact that we are perceived as the enemy and ask why and then figure that out. I don't think we do a good job listening to the MSM community. And people say that, gay men have condom fatigue or other types of things. I said, well, that's fine. Where can we help them if it's not to use more condoms? Is it to find better health care? What types of things can we make a difference on? And I don't think we do a very good job of listening. So, one of the things I want to work with David on is to listen, figure out how can we listen more and adapt how we approach things rather than our standard lines of get tested regularly and use condoms. I think we can do a lot more than that. I also think what Ronnie puts up here too is he says public health is the enemy. Public health represents the government, and many, many gay men see the government as the agency, the enemy. We can't get away from that, and we don't want to be the sex police, but I think often we're in denial that the moment we call up and we're from the state health department, we're going to alienate people, and how do we get around that? And I think we have some soul searching to do around, because most people in our programs, they're not homophobic, they want to do the right thing, but just who we represents a barrier in itself. So I think this is a great question and where we have a lot of inroads. And especially, to be quite frank, during these times and the current debates about social issues in our country and who's in power, I know many people in the MSM community, including myself, I feel very alienated. So we have our work to do on here.
Yeah, Tom, this is David again. I couldn't agree more. I think we do need to listen in new and different ways, and I think there's lots of opportunities for us if we go about doing this right to really make a difference. And working with community leaders, partnering with community-based organizations, working with our providers. These are, the sky is the limit in terms of the work that could be and needs to be done here. And I would say that even more urgent than that. I mean, we are working very, very hard at the national level to raise the visibility of our sector and our field and to offer the expertise that we bring. And just a little bit of an example of what happened yesterday in terms of our success in Congress. There will be people and organizations that are very interested in pushing back on us. Our team here will tell you that I have said this on several occasions. With increased success comes increased scrutiny, and we have more of a responsibility than ever before to lead. And part of leading is listening in very important, new, and different ways, and then having communities experience that we have listened and then implemented what they have recommended. So this is a very big, hot, juicy topic that we need to take on. So thank you.
And David, if I could just add too, I think we have to hold ourselves to the same standards as we do others. I know all of us have recommendations how to make a doctor's office and their visit be gay-friendly. But are we making our health department services as gay-friendly? Do we have a website for gay men? Do we make it clear? Do we have documents that include gay men in them? That I think there are many things as an institution we could be doing to make our services and our institutions as gay-friendly as we expect doctors' offices to be. And I think that's one of the points of the report card of, oh, let's look in the mirror for ourselves. How well are we doing in this area?
Yeah.
Great. Does anyone else? We still have time, so
yeah.
Other questions or comments? David, do you have?
I was just going to pose other questions and feedback specifically for NCSD as we go forward. Tom just made this point, of course, about listening, and the goal of this segment, of course, is to listen to all of you. So do speak up if you have any questions, observations, or thoughts. Tom, is there any question that you want to pose to us at the NCSD staff level or participants on the call?
I'll just pose this, and I think this is one of our challenges, and its reality is that many times when I've introduced this topic, people say, well, Tom, you're from a progressive New England state, a very blue state, and this could never work in my state. And I appreciate that. And I do think that's a challenge for us, David, to the degree we have a report card and a self-assessment. One of the barriers for some of these states across the country are to actually implement some of these efforts. Even just adding sexual orientation onto a BRFSS survey is a challenge. And so I just think we need to be super sensitive to that and listen to those states about how we can, be supportive or apply pressure. I'm not sure what the answers are, but I want to be sensitive to that also. That some of this stuff is easy for me to say in my state, but I certainly don't have many of the challenges I think some of my colleagues have.
Yeah, I think that's a good point, Tom. Ronnie has written another question, which again is another one. Why is partner notification a sticking point? Well, Tom, I'm gonna let you comment on that, but I think from what I've learned and observed and listened to over the years, but also in particularly the last year and a half, I think there's a lot of misunderstanding about the role of DIS. People don't understand the role of DIS outside of our sector, and people don't understand the utility or wisdom of partner services. And again, we have a big job to do here to demonstrate how these services can help, and that we're not the sex police. But that is a big hurdle for us to get over. Tom, what would you add here?
Oh, yeah. There are diverse opinions across the country about the effectiveness of partner services for gay men. My own personal belief is that when people call gay men a hard-to-reach population, I say, no, we actually have hard-to-reach services. And so I disagree with people who say it's time to stop doing partner services for gay men. I think it's time for us to step up our efforts and do them better. Pointedly, too, I will be critical of the CDC. Last year when they put out their POMs for the apps, there were two big reports in there around partner services, one on syphilis for women and one on partner services for straight men. I thought there was going to be I was missing something. I called them up and I said, where's the metrics for gay men? And they said, oh, we don't produce them. So this is, it is a sticking point. I think it requires a lot of discussion and soul searching and figuring out the best path forward.
Are there questions, Tom, you would pose to us or participants on the call?
Nothing else. I think the only thing, David, I don't mean to put you or Neel on the spot, but do you have a target date to finalize and roll out this report card in the future?
That's a good question, and maybe we'd like to determine that in working in partnership with all of you. I think you mentioned, Tom, that of course the tool is in an Excel spreadsheet in terms of a format right now. That was intentional. I mean, we want to hear feedback and input on that, and then we're gonna put it out in a little bit more sophisticated, graphically designed manner as we go forward. It'll take us a little time to put that together, but I think we also wanted to ensure that we're allowing some opportunity for feedback input on the very design of it. So I think I might defer to you, Neel, and Tom in terms of thinking of timing here.
Yeah, I mean, I think this is something that we want, like we said during this whole presentation, we're taking this up and we're really putting our weight behind it. And as such, we really want to be very careful and intentional about everything that we do with this report card and really make it the best product that it could possibly be. So that will probably take some time. I just giving you a softball estimate could be a couple months, maybe 3 or 4 months. We could develop it a little bit more, Tom, get people's feedback, and just produce something that we both really, really love.
Okay.
hopefully maybe a little sooner. I might just add. Not that no, we got a lot going on here. I don't want to stress anybody out, but if we can get it done sooner, that would be all the better.
Definitely.
But, we can talk about that now, Neil.
We're definitely going to do this. We're not going to put this on the back burner. This is on the front of all of our minds. I don't want to promise everyone a certain date and we go past it.
Yeah, that's good. Manage expectations.
Well, it looks like we're approaching the time, so unless anyone has any other last-minute questions, I just want to thank Tom for not only being the brainchild of this whole toolkit, but also agreeing to give a whole webinar on it and putting so much effort into it. And I want to thank David for taking some time out and putting his weight behind this and expressing how important this is to NCSD. So thank you both for both of your contributions. And I look forward to working with you, Tom, on really improving this tool some more and taking some of the feedback we heard during this webinar and applying it and fixing it. So with that, Tom, unless there's any last-minute comments you'd like to make, I think we'll close out. Tom?
Okay, so my pleasure to be here. Thank you for having me.
Thanks, everyone. Have a great day.
Thank you all.
Bye now.